My body knows how to do it.
It's a girl.
As we speak, every second, a woman gives birth somewhere in the world. It may sound ordinary, but for the woman living it, birth is nothing like that.
Welcome to Born to be Wild, the podcast. We call in guests from Portugal and beyond to share real birth stories and lived experiences, and to explore what maternity care really feels like on the ground.
In this podcast, we invite you to listen, question, and sometimes unlearn what pregnancy, birth, and postpartum are supposed to look like.
For us, wild means staying connected to yourself, your body, and your choices, even when systems make that difficult.
So let's begin. Imagine catching your own baby with your own hands. And it's not a metaphor, literally. For most of us, that image belongs to a vaginal birth. But what if we told you that it was possible during a cesarean? What if, even in an operating room, you could be the main character of your own birth, not a patient waiting behind a drape, but the woman bringing her child into the world?
Yeah, in this episode, we speak with Koen Deurloo, the kind of obstetrician many women around the world would dream of having by their side during birth. Over the years, he has deeply challenged his own way of practicing obstetrics, largely because he chose to listen closely to women and their birth experiences. And about 10 years ago, he introduced a new innovative approach in the hospital where he works. It's called the MAC method, or the Mother Assisted Cesarean.
For several years now, Koen has been carefully documenting this practice. He consistently collects and analyzes data to demonstrate not only that the procedure is safe, but also the benefits it can bring for the mother, the baby, and the couple.
Yeah, and today he works to raise awareness and share this approach more widely. For example, in our podcast. In this episode, he tells us how the method was born, how it works in practice, and how it can transform the experience of cesarean birth. He also speaks about what it takes to become a doctor who truly listens and how the system can help you in your favor. And also why preparing for Plan B might be one of the most important things you can do before you give birth. Unfortunately, due to a health issue, Aviva won't be participating in this conversation, but you will of course hear her next time again. So let's dive into these topics with Koen Deurloo. He's a gynecologist in the hospital Diakonessenhuis in Utrecht in the Netherlands. And he's very much into women-centered care as an advocate for the Mother Assisted Cesarean. Hi, Koen.
Hey, hi. Irene, how are you?
Good. Thanks for being here today and thanks for joining us on the podcast.
Yeah, thanks for having me.
Hey, can you please say a few words to introduce yourself, your practice, and how did you decide to go to obstetrics?
A few words.
Yeah, is that
So,
possible?
well, I'm Koen. So people call me Koen or Dr. Koen most of the times. Also, the women I guide. So I'm an obstetric gynecologist or perinatologist. This is an expensive word for over 12 years now. And I came into this field. I wanted to become a perinatologist after my experiences in my internships.
Okay.
So that's when I noted that this field of medicine is covering everything I like. So very positive experiences. You can be a really good doctor for women if something happens. Most of the time, they're young people, young women who are very easy to adapt to changing circumstances. So there's a lot of innovative things going on and possible with these women. So that all together, that's what when I decided to become an obstetrician.
Okay.
Especially when I was allowed as an intern to guide my first delivery. Well, guide, I was just standing there, just catching the baby under the eye of a very experienced nurse. So, but I felt so good about it. I thought, okay, this is what I want to do the rest of my
That
life.
was the
So
way to go.
this was the way to go. Yeah.
Yeah. So you decided to work as a doctor, and what
Mhm.
drew you to becoming a doctor then?
Well, several things. I'm from a family of doctors. So my dad was a doctor. He was a KNO arts, which is throat, nose, ear. So I'm not sure
Yeah.
if I'm using the correct English term. So he was a doctor, and my mother was a nurse. So I grew
Yeah.
up with with medicine. And my father was a really empathic doctor. So when we were out, so there were a lot of patients always say, "Hey, how are you doing?" So I had a very good feeling about this being doctor.
Mm-hmm.
And my wife, when she was young, she spent some time in the hospital, not something serious, but she needed time to recover. So then I stayed with her to help her recover. And then I noted also, oh yeah, these are my people. This is what I
Nice.
like. So after when I was 19, I decided to go into medicine and med school.
Nice. Okay. Hey, and nowadays you're practicing as a OB-GYN,
Yeah.
as we call it in English, and your work has become like kind of famous. Not, I don't want to call it famous, but it went across borders
Yes, it
because
does.
you kind of are the first person in Holland to
Hmm.
practice the MEC, the Mother
Yeah.
Assisted Cesarean.
Yeah.
Can
True.
you please explain to the people listening what that exactly is? Is it completely new, or were you inspired by practices in other countries?
I know, of course. No, well, I hadn't heard about it until a pregnant woman came to me, Camilla, and she came to me with a doula, which was really nice. I knew this
Mhm.
doula for a long time. And she came to me and she had a very traumatic birth, which ended in a vaginal birth, not a C-section. But she was
Mm.
really afraid of losing her life or the life of of the life of her baby. And she told me in that appointment, I think it would help if I would be able to guide my baby out with a planned cesarean. And I haven't heard about it. Well, I haven't heard a bit about it, but then I never read about it and then saw anything about it. So, and the doula who was with her, she was smiling because she didn't prepare me. So she was sitting there grinning like, okay, I'm curious what you're gonna say.
Yeah.
So, and I said, well, I'm gonna find out. So I was really intrigued by her question, and also she could really explain really well. For this is going to help me. So I was kind of motivated to take care of her. And then I decided to ask some of my colleagues who are very innovative and are always enthusiastic for new things. And we just tried. We just got a doll and we put it on top of someone in an operating room, and we start just draping women with sheets and trying to, how is this possible? There wasn't anything on YouTube or on
Mhm.
PubMed. There was nothing. So we tried and tried and tried, and eventually we thought, well, this could happen. This could work, and then we did it, and it
Okay.
was amazing. So we really liked it, and the whole operating room felt silent when she lifted her baby out. So it was a very emotional moment, and then we all thought, okay, this is something we like to continue to do.
Yeah.
And
Yeah.
it's only slowly develops over time. From once a year to now almost 100 a year now.
Wow. Oh,
Yeah,
that's
in
super weak.
9 years now.
Amazing.
Yeah, so there is, I don't think everybody wants a Mac or needs a Mac.
Yeah.
Everybody is invited to have one, of course, or to work with me.
Yeah.
But I think most women would like just gentle C-section, which is also very nice and comforting. And there's this small group, I think, traumatic women, women who are really aware, who are like to be part of the operating team. Uh, um, they opt for Mother Assisted C-section. In our hospital, it's about 10 to 20%, I think.
Oh, wow. Hey, and just to be clear, like the
Hmm.
Mac, it's all about the woman lifting the baby out of her belly herself. But how does
Yeah.
that exactly work?
The procedure is kind of like a normal C-section.
Mhm.
So it's planned, it's low risk. And these women are also getting spinal anesthesia. But after that, it changes a bit because they need to work with me in the operating room. So
Mhm.
they have to be like me. So sterile gloves, sterile rope. So we
Yeah.
need to get them dressed.
Yeah.
But it ends up that the mother is on the operating table in a sterile robe with gloves, with the hands on her chest, just waiting for me to open up her uterus and then pushing the baby out a bit, just like a tube of toothpaste. You press here and the
Yeah,
toothpaste
that's a
comes out there. You
nice
press here
comparison.
and the baby comes out low. And when the baby comes out, she'll be there waiting with her hands.
Yeah.
So the baby will be welcomed by her hands. And we're just slowly pushing slowly the baby out in her hands. And especially women who lost a baby or had traumatic experience, it's a really nice experience for them. And then I have to help them a bit. So the baby is born in their hands, and then I'm going to help them a bit, lifting the baby under their shoulders, and then they slowly lift their baby out. Well, they can admire the baby for a few seconds
Yeah, of
or
course.
maybe a
Yeah.
minute. Yeah, whatever. And then their sterile robe has a little cut in between. So
Yeah.
just before she's going to start cuddling, we rip open or we tear open the shirt a bit. So there's
Yeah.
bare skin, and she immediately is skin to skin. So the
Oh,
difference
wow.
between normal C-section is you'll be the first to touch your baby, and
Mm-hmm.
there's no one in between you and the first skin-to-skin contact,
Yeah.
and the baby stays with you if everything is okay, of course.
Yeah.
So there's no separation.
Yeah, because I can imagine it's a main concern of women that babies like kind of taken away after a
Yeah,
C-section, right?
all right, that's it. So there are a lot of women who don't like that, and
No.
I truly believe it's not necessary. So
Yeah.
sometimes it is. So you should have specialist or a pediatrician on your operating room checking the baby, of course. But
Yeah.
there's no need in routine checkup and just separating mother and the baby only
Yeah.
when it needs to.
Yeah, exactly. Only when it's necessary, of course,
Yeah,
then the medical
yeah,
intervention is needed, but otherwise it's
absolutely.
all natural.
It is, and it's a better start. It's you feel more powerful as a woman. It's better for breastfeeding. It's better for attachment. Babies like it. It's better for your recovery. It's less painful. So there are a lot of things to gain just
Yeah.
by doing nothing and watching, just watchful waiting.
Yeah, exactly. Hey, and I can imagine, because it's an unconventional way of letting a baby be born.
Mhm.
Did you meet any resistance? Was that true?
Well, resistance, I would say surprise
Yeah.
and also hesitancy to step away from the routine. But
Yeah.
that's with every innovation. And so at first we did notice, so why are you doing this? Huh? Because it changes the procedure a bit. We didn't know at first, but it might add to risks, yeah? So such as temperature loss or sterilization, infection rates or blood loss. It isn't, unfortunately. So I've checked that over a few hundred max. But that's what the main concerns of caregivers. But I noted once people saw what we did to these couples, not only the mothers, but also the
All
partners
the
who were also
fathers.
involved and sometimes also traumatized, they know, okay, this is really helping them. So, and
Yeah.
they're all caregivers. So all caregivers want, yeah, they care. So if they see something which is better care, they're more easily convinced that this is good. Not everybody, I have to be honest. So we have some difficulties also in Holland to implement this in other hospitals. But over time, I see when you notice how
Mhm.
much this works for couples, yeah, people tend to change.
And you said some difficulties. What are the difficulties you're facing then in other hospitals?
Well, recently I had a medical student, and I was also very curious about that. Why won't you implement this? Because
Yeah.
it's safe, it's nice, it's a good start. You get the mother involved.
Yeah.
Not like some victim just laying there. No, you actively participate. So they're all wins. So I asked the medical student, or she asked me, can I do some research? I said, yeah, well, we can do some research. You can ask hospitals why they don't implement the MEC.
Yeah.
So she asked about 15 hospitals in Holland. So why don't you do a MEC? And so I got this whole list of
Oh,
excuses
that's
now.
interesting.
That's really I'm going to publish this on my Insta very
Yeah.
soon. But for now, I noted that most people who are the most hesitant don't exactly know the procedure.
Yeah,
So
okay.
they think about lifting your baby out and what a bit all the tissue and the blood and inside your abdomen that must be
Yeah.
strange, and maybe you grab a bowel. So but it's nothing like that. It's really sweet and nice.
Yeah.
So there's a lot of disinformation or no information, and people are worried, and that's their job about blood loss or temperature loss or
Yeah,
infection
exactly.
loss. So I keep track on all the women I perform the MEC with and collect all the data, and I don't see any changes in blood loss or temperature loss or complication rate. What I do see is a big gain in trust, in self-confidence, in experience, in breastfeeding. So, and the only cost of a mug is it takes a bit more time because you have the mother to get dressed, all
Mhm.
sterile.
Mhm.
That takes about 4 to 6 minutes.
Yeah.
So, and it costs two sterile pair of gloves and one rope, which is in
Yeah.
Holland about
Okay.
9 to 10 euros. Okay.
Yeah.
And that will help these parents really get a really nice experience, but which sometimes is also referred to as a healing experience
Yeah.
when they had this really traumatic experience. So it's just this for this game.
Yeah.
So
It takes like a pair of gloves and a sterile suit plus a few
that's
minutes
it.
extra,
That's
and
it.
it has a huge gain. Yeah, that's amazing.
So all this data is now collected in this big data pool, and it's been submitted to a scientific journal. So hopefully, when this gets published, people around the world, especially in Holland, will see, okay, it's a safe procedure. We might want to reconsider doing this in our own hospital.
Yeah, I can imagine. But you say especially in Holland, but I can imagine like we are also talking about maternity care in Portugal.
Hmm.
And like for these countries who have like a more conservative maternity care system, it might
Yeah,
be super relevant as well.
I think so too. Yeah,
Yeah.
definitely. So I do get lots of requests from around the globe. So last year, I helped Argentina with their first mother assisted C-section. I've helped numbers of hospitals in Norway or in Belgium to do their first mother assisted C-section. It's not that difficult. It's just, I usually talk to them just by Zoom or Teams, explain
Yeah.
to them how it works and go through this procedure, and then it's done. So
Yeah,
it's not
I
so
can
difficult.
imagine. These guidelines you make, like
Hmm.
for like a Mac, for example,
Hmm.
these support women. But do you know of any guidelines in the maternity care that quietly maybe undermine the autonomy of women as well?
Very good question. But that's not just the guidelines, I think. That's the way we think about guidelines.
Mm-hmm.
So care is not ruled by guidelines, although sometimes people think that is. So, care by protocols is not by definition the best care.
Yeah.
And we should keep mentioning it also to the trainees and the interns and the residents that good care is a combination of several factors which include guidelines. But it also includes the woman. What's important for her? What's quality of life? Which risk is she willing to take? Which risk is she not willing to take? So
Yeah.
for some women, a primary C-section can be a very good option, and for some don't, with exactly the same medical indication. So maybe your protocol says you should offer C-section, but maybe the woman says, well, with my quality of life, because I don't know, I'm a professional dancer, or I'd like to give birth to 10 more babies, I don't want to start with a C-section. That's different.
Yeah.
It's different from someone who's 45, who had a year-long fertility track with their last chance of a live baby, and you offer, and they might accept a C-section. So we should recognize the differences in women, and that's sometimes which our system fails.
Yeah.
And we look too much at protocols, and protocols and guidelines are, yeah, well, they're to guide, they're not
Yeah.
to rule.
They're not leading.
What sometimes people tend to overlook, we offer care
Mm-hmm.
because we are afraid of complications, and those complications are usually rare or low percentages.
Mm-hmm.
So sometimes women say, why would you offer me a hospital birth when the risk of a complication is a half percent?
Yeah.
But people
Exactly.
should realize that, yeah, but people should realize, that's the other side of the medal, that a complication rate of a half percent is what we see 6 to 10 times a year.
Mm-hmm.
So your doctor or your caregiver is influenced that these low risks are happening often.
Yeah.
So, and that makes them also sometimes more worried than they should. So the combination of woman, doctor, and protocol.
Can we say that decisions are sometimes made out of fear?
Fear, well, I never questioned the intentions of caregivers. I don't think you're gonna last long if your intentions are greed, or power, or money. So you should have your intrinsic motivation to care. So, and there might be a few exceptions, but most caregivers, they want to care. They really intend to do good.
Mm-hmm.
But you have to acknowledge by yourself that you can be afraid as well, that you are worried about complications which happen to you, that which you
Exactly.
experience, which doesn't tell you anything about this woman.
Yeah.
And
exactly.
you shouldn't change that much, but you should know, you should be self-aware of these limitations in your opinion, in your caregiving.
Yeah, because if we're making a bridge like towards Portugal, the
Mm-hmm.
C-section rate in Portugal is like 36, 37% in
Mm-hmm.
like public hospitals, but in
Yeah,
private hospitals, it's 65 to 80%. That
that's
also has a financial factor because C-sections are just more costly than normal births, like vaginal births.
yep, they're
So
planned.
that's a worrying that those are worrying facts. And I
I
can
think so too.
imagine, yeah, the high C-section rate is also because of the birth culture in a country. Like it's different in Holland compared to Portugal, where the system is very
Yes.
different.
Mm-hmm.
What do you think? Like the Netherlands is a unique system. Like of midwives are the first care providers for the pregnant women.
Mm-hmm.
And that's unique in the world. That almost never happening somewhere else in the world, and especially not in Portugal. So in Portugal, voices are being raised about like the high C-section rates, but also about the high intervention rate. We had a like a small conversation prior to this podcast, and I told you
Mm-hmm.
about like how some doctors might think and how they look at other caregivers, etc., etc.
Mm-hmm.
How do you see the role of the midwives and the doulas in like a hospital setting?
Yeah, I think they're very important. I think it's in Holland we look at pregnancy not as a disease,
Yeah.
and we don't look at delivery as a treatment. Those are just physiological phenomena.
Mhm.
So healthy women should be able to give birth and have a healthy pregnancy. So you should have a caregiver which focus on health and preventive medicine.
Mhm.
And if that changes, then you get a doctor because a doctor is trained to see pathology. So I'm like a hammer. I see nails everywhere. So I start banging. So, but some nails don't need banging. They just need to watch. And I think that's what helps us getting the intervention rate low in our country.
Yeah.
And some people might suggest, yeah, well, your intervention rate is low, but your mortality rate and your morbidity rate is very high, but it isn't. So our
Why do the
mortality
people think
rates,
that?
well, home deliveries are considered dangerous
Yeah.
because people feel they offer that intervention to save a baby or save a
Yeah.
mother. So if somebody says, I don't do these interventions, they think, okay, then you probably have high complication rate.
Yeah, exactly. Because you hear a lot of women saying, like, oh, thank God I was in the hospital because otherwise I wouldn't have survived it or my baby
Yeah,
wouldn't have at the moment. But
yeah.
how do you distinguish then between a necessary intervention and an intervention out of habit or maybe fear?
Yeah, that's difficult because in the end you have a living, crying baby in your hands and everything is fine. So
Yeah.
people are very grateful and people are at their happiest moments in their life. So it's difficult to be critical. So that's what I like about this job. Eh? So it's a very positive
Yeah,
job.
I
So don't
can
get me
imagine.
wrong, I really like that. But yeah, it usually ends well. Well, you have to compare and you have to be open-minded.
Mm-hmm.
So question the routine. Say, is this really the way? And I think the routine should be questioned by women, not by doctors. In Holland, we have 1,000 gynecologists, but every year we have 150,000 pregnant women. So
Wow.
the change is not going to come from these 10 or 30,000 doctors, but well, there's going to come by the women. So if you start listening, then you notice what they want, what they think about your intervention, what they think about your participation or your shared decision making. And that's what helped me a lot in becoming the doctor which I am today, just by
Yeah.
listening to what women told me or what they were afraid of or what they wanted. And sometimes they have strange requests like, I'd like to have I don't know, I have to want my partner participating in the surgery so he can lift out the baby.
Oh,
So, and
wow.
and people were telling me, you're not going to do this. They're out of their mind. So, but there's a question behind because they ask you this because they think it will help them in some way. So stop saying no. Stop saying this is stupid or it's not safe. Say, why would you want that? Why would
Mm-hmm.
this help you? And eventually you will get there because our partners are now more involved in MAC due to questioning by women say, I like my husband to be more close to the birth of my baby. So
Mm-hmm.
it's difficult because they're not trained, they're not authorized to be part of the surgery team, so it's very difficult. But you give them a better role in supporting the MEC, and that's exactly what we did. And
Yeah,
now I get
exactly.
these questions a lot less.
Yeah. Yeah, I could imagine.
Just listening.
Yeah, but for some people, just listening is very hard when you're like all over protocols and everything. And don't get me wrong, I'm very positive about hospital care and especially in Holland. I had my first baby in the hospital
Thank you,
and
thank you.
it was amazing. Yeah, it was in Deventer ziekenhuis and it was really good. The care was really good. I loved it. And I recognized the moment you're telling about like when you have the baby in your arms for the first time, you tend to forget about everything that happened before.
Yeah, yeah,
But
it's
it's
beautiful.
also for women, it's kind of hard sometimes to find their voice in the delivery room or even before to question some protocols.
It is. You're in strange territory with all these white coats. There are many of them, and you're just you and your partner in a strange setting. They learned for it. They trained for it. They went to school for it. Yeah, got all these expensive words. So yeah, you're 4 to 0 behind. So it's
Yeah,
difficult. So I do try to empower women that it's not strange to question the advices you get. Not because you question your caregiver, because you want to talk about what's best for you.
exactly.
So because your caregiver knows all about protocols, he knows all about his own experience, knows all about the logistic of the hospital, what's possible or not. He doesn't know you. He doesn't
Yeah,
know what's important to you. He doesn't know your fears. He doesn't know your future. He doesn't know your family planning or your interests. So you should help him saying, yeah, I get your advice, but these are things which are important to me. And you kind of rule that out, or you're not paying attention to that, or I think this option is not fitting, is not good for my planning. This doesn't fit. And that's
yeah,
not harsh or brutal or, I don't know, uncivilized. It's just normal care. And I think when we start doing this in daily practice, listening, care would be better
yeah. I think
because it
so
won't be
too.
protocol care, it will be participated care with the women. So you get
Yeah,
better care.
you're doing it together,
Yeah.
right?
Yeah, because I'm going to care for you. So you should be also involved.
Yeah, exactly.
Just like without medical
Yeah.
intervention. So if we're gonna do something, yeah, you're gonna be part of it. So I'm not gonna plan the whole day for you.
Pregnancy can be quite overwhelming for women, especially
Absolutely.
when it's their first, especially when things don't go the way as they planned.
Mm-hmm.
Especially in these times, like 2026, a lot of women are used to
Mm-hmm.
like life is going according to plan, and when it's not according to
Yeah,
plan, it
kind
can
of.
be hard. Well, I'm just
Yeah.
generalizing things right now, but it
Yeah.
can be hard.
I recognize this. Yeah.
Yeah, you recognize this. What
Yeah.
would you say to these women?
Well, prepare. So, and not only you, but also I think some caregivers should also prepare their women.
Mm-hmm.
So, for instance, this is my go-to to explain this. So, when you were pregnant for the first time, did you know the chance of you ending up in a hospital in Holland? You are healthy, you're young, you're slim. So, what would you guess would be the percentage that the hospital would take care of you in your pregnancy or in your delivery? You know, first
No, I don't
timers?
know. No.
It's about 80%.
So, wow.
Yeah, that's a wow. A lot of people say, "Oh, wow, that's a lot." Yeah, it is. It's a lot.
Yeah.
So you're not failing the system or you're not failing yourself. This is just what happens. 80% of the first
Yeah.
timers will get in the hospital. Start telling people that. So I won't be there, but I think my colleagues should tell you this. And for example, the cesarean rate in Holland, it differs over different regions, but say 15 to 20% overall.
Yeah.
So nobody tells you that. So 1 in 6, 1 in 7 out of the women, first timers, slim or not overweight, are ending up in a C-section. 1 in 6. So nobody talks about that. What we
Yeah.
do talk about is the NIP test, for instance, of the
Yeah.
chance of you getting a baby with it. That's 1 in 1,000.
Yeah.
Or we also talk a lot about the 20-week scan. That's
Yeah.
3%. So sometimes people say, yeah, we shouldn't worry women with these numbers because they get scared. Well, you're not scaring them with the
Well, it's
NIP and you're
realistic.
not scaring them with the 20-week scan. So start telling people what's about. And it's all about the tone. So don't say to
Yeah.
people, start worrying, it's going to be bad. No, say this is realistic approach to your birth. So you
Yeah.
should have a plan B. You should have a plan C. We're going to be with you all the time. And if it scares you, it's good to know because we can take care of your worry now and not
Yeah.
when you're there and you don't know anything.
Not
So
during
that's
birth
my
or after even.
or years after
Yeah.
sometimes when it reoccurs when they're pregnant again and start going for their second delivery, and then all of a sudden all these suppressed traumatic experiences come up.
Yeah.
So I think we as a care community, we should really look into that, preparing women better.
Yeah.
So that's what I'm trying to do as much. But yeah, not just me. I need to do it with my colleagues.
Exactly. Hey, but I was also wondering, like in the beginning of this podcast, you mentioned like, okay, birth is a natural process.
Yeah.
Many women want to give birth at home in Holland for their first. Not many women, but a lot of women, but they end up in the hospital anyway. So what's the deal with that? Like, okay, birth is a natural process, but in the end they go to the hospital, like 80% goes to the hospital anyway. How is that?
Yeah.
How does that go?
Well, that's the way we've organized things in Holland. So
Mm-hmm.
don't forget, Holland is like very small. So
It
if you
is,
give
yeah.
birth at home, you are always next to a hospital. It's different in Canada or in Norway or I don't know,
Yeah, where you
China
have to
maybe.
drive like 3 hours to get to a
Yeah,
hospital. Yeah, of
yeah,
course.
and it's all about chances and risk. So if you are willing to give birth at home, there are a lot of advantages. So you have your own midwife who knows you. You have a very
Yeah.
intimate experience. You have a safe environment, you know. So those are a lot of gains. On the other hand, if there is a complication which you need a doctor, you're going to delay.
Mhm.
So you need to get to the hospital. So
Yeah.
these little complications you have, because usually low risk women opt for home delivery. If you have a low risk, then if you want to go to the hospital, yeah, it increases a bit. And then I would ask the couple and the woman, are you willing to take that risk? And if they say,
Yeah.
yeah, I think it's
Yeah.
a good way, do it. And if you don't, come to me.
But that's
And then we'll
informed
work.
care, right?
That's
Yeah.
it. And that's how it usually
How it
works.
works.
Yeah, and prepare women. So a lot of home we have about well, you have to ask a midwife, but I think 10 to
Yeah,
12% home
exactly
deliveries, which is
12%.
which is low compared to the turn of the century, which was about 30, I think. So
Mhm.
it gets low, but also because midwives tend to guide birth in the hospital. So it's like
Yeah.
a home delivery in the hospital.
Yeah.
So it's we're still not involved.
It's in a
So, but
birth
also
house, right? It's like in a birth
that's what
center.
we
Yeah.
call a birth house. So that changes, which wasn't there before the turn of the century. So I think it's good because we now have some really well-trained professional, the midwife, who looks after, and when she recognizes pathology, she will talk to me, what should we do? And
Yeah.
then we can, and what does the women want? And then we should arrange, take care in the hospital. And I'm not so sure the reason why 80% ends up in the hospital is also it tells us something about the risks we are willing to accept and not about the risk itself.
Yeah.
So some women, the most women, these numbers tell me that the most women are not willing to risk that much for home delivery. They don't want that. They say after
Mhm.
a certain threshold, they say, okay, go to the hospital, and that's 80%.
Which is fine, of course. It's totally fine. You
There's
have
no
to
right or wrong.
yeah,
60, 100, I don't mind.
you have
As
to
long as
give
the
birth
care is
where
good.
you have to give birth where you feel
Yeah.
most safe. Yeah.
Yeah, and well informed.
Yeah.
So you should know your risk, and we should know your advantages because when we take over care, it doesn't stop there because there was
No.
a reason for you to give birth at home. So we should
Yeah.
try to mimic those circumstances, those scenery to help you. That's why it's
Yeah.
important we talked
Yeah.
during pregnancy or we talk at the very beginning.
Can you recall a moment where centering the women changed the whole clinical decision?
Yes, well, many times. For what we discussed previously, Camilla, she questioned
Yeah.
our system. So we invented the MAC. But as I wrote in my book, I've met several women who changed my perspective on care. And there was this woman. I recall I was just a young gynecologist, I think 1 year or so. So I was really
Mhm.
convinced I was doing the best. And she had a small baby inside her. And we were not exactly sure that it was growth restricted, but we were kind of worried. So I told her, I think it's better you have an induction. And she
Okay.
said, no,
Okay.
no,
Oh, wow.
I don't want to.
Yeah.
And I was a little bit surprised and
Can
confused
imagine.
because why wouldn't you want that? So instead of exploring her fear, I kind of repeated my
Yeah.
advices. So I was intrigued by her no saying. So we spent quite some time together.
Yeah.
I think we had 2 or 3 additional appointments because I couldn't understand why you wouldn't have yourself induced. And eventually she had her induction. She had a small baby, but not too small. So there was a healthy crying baby in her
Okay.
arms, and she came to me after the appointment. And well, I usually ask her, "How do you feel about it?" She said, "I don't feel good because you pushed me into induction."
Oh, wow.
I could have said no. And then I realized, yeah, you're right. I should have explored more why you wouldn't, because I kind of pushed her into the induction because of my own fear,
Yeah.
but I needlessly didn't allow to see that she would have to give up her preferred delivery place, her
Yeah.
own midwife, that
Yeah.
she had to deal with people like me and white coat. So that really changed my perspective. So I really think about her quite some time when people say to
Mhm.
me no. So I know this emotion from when people say no to your advices. You might be surprised or irritated or a little bit hurt because, well, I've trained a lot. So I think I know, but I don't know you. So that
No.
took me some time to realize. So, and that really not changed only her health path, but
Yeah.
it changed my perception especially.
Oh, wow. But I think it also applies to a lot of doctors now
Mhm,
that when a patient says no, or like in this case, a pregnant woman says no, or says something else than you would advise her, uh,
mhm,
it requires a lot of self-reflection as a doctor or as a
absolutely.
medical professional to deal with that.
It does because you also feel that and know you trying your best. You try to give good care. Everybody does that. Also in Portugal, everywhere, even with high cesarean rates, I don't question the intention of any caregiver in obstetrics. But I do think that sometimes they overlook the perspective of the woman
Mhm.
because even if the advice is good, it could still be not a good advice to that woman
Mhm.
because she has other plans or she needs to give up things which are very important for her. If it solves risk she doesn't care about or it creates risk that she doesn't want to happen.
Exactly.
So you should really recognize that feeling, and I do now, and get beyond that. So, okay, I'm a little bit hurt now, but forget it. It's not about me. Why? Why do you say no? And women are entitled to say no, of course,
Of
because it's the
course, yeah.
law. And you should have an informed decision. You should have an informed consent. So women say, yes, I do. But sometimes they say, no, I don't. And that's informed refusal, which is also fine as long as it is informed. Only it doesn't stop after informed consent or refusal. You need to explore further. Okay, what can we do to help you? What can we do to change that? How do you see it? Why do you say no?
Mhm.
And
Mhm.
that's something which lies beyond your first emotional response.
Yeah.
So I try
Yeah.
to help other caregivers also to recognize that, put that away, talk to you to other colleagues about that,
Yeah.
but try to stay giving care to this woman, even if it hurts you or surprises you or no, I don't know,
Yeah, no, and then I
irritates you.
can also imagine, like, as a doctor, you see all these kinds of situations in your day-to-day practice. Every week, something happens that you're not happy with, maybe.
Yeah,
And I also can imagine, like, you're the fear of, like, delivering a dead baby, maybe, or something
yeah,
like that is very present. Do you recognize that?
yeah, definitely. So even small risks, such as 0.1%
It's a
in a
risk.
hospital my hospital, we do over 3,000 births. So a risk of 0.1%, 3 times a year.
Yeah.
Yeah, that's every 4 months. So that's kind of frequent for us.
Yeah.
So seeing babies pass away is very intense. And I choose this job to help parents to see in their happiest moments in their life.
Yeah.
But instead, sometimes you have to witness the worst moments of their life. And it's even worse because they expected the very best moment.
Yeah.
So you really try to do everything you can to avoid that.
Mm-hmm.
And so your intentions are always good, but you should also recognize that the fear is not always the best motivation to give advices. So you should
No.
recognize that as a caregiver. And also, I think the other way around, women should see that we do deal with a lot of complication, with a lot of grief and serious complication we feel we need to avoid that. And I think that's also sometimes the experience that women have with doctors.
Right?
Yeah, they see one side.
Yeah. Okay, that's very interesting, Koen. Hey, and my last question is then, like, if maternity care were redesigned with women's rights at its core, what would change first, you think?
No, it should be already like that. I think
Yeah.
you're the most important role in the whole situation. I think we should really look at women as a part of the team which has their own expertise. So just like doulas, it took some time to incorporate doulas in our medical team,
Mm-hmm.
but now she's here and she has her own expertise. She has her own professional communication and she helps us. So she adds to the team. And I think we don't see that all the time with women. I think we should really see them also as part of the team. So they bring in their knowledge, they bring in their experience, they bring in their wishes and their
Yeah.
fears. And if we start listening to that from what's important and we incorporate it in the guidelines, the doctor experience, and also the logistic of the hospitals, because some hospitals are other owners, then in the center you get the best care.
Exactly.
So
Okay.
I think you will get better care if you incorporate women
Yeah.
overall.
Super interesting. Let's aim for that. Also
Yeah.
in
Yeah,
Portugal.
I'll be
It's
with you.
very important. Hey, and you wrote a book, right? But
Yeah,
it's in Dutch, unfortunately. So
it
for all the
is. Yeah.
Dutch speaking people listening right now, we will link it in the show notes, of course. It's
Thank you.
called, like, literally translated, it's called Through the Eyes of the Gynecologist.
Yes.
And I read it myself, and it's very interesting to read, also
Yeah,
because
thank you.
you highlight all these different perspectives and all these different situations, and you get like an insight in how maternity care in a Dutch hospital is being done, and that's
Yeah,
super interesting.
thank you.
Thank you so much. Thank you so much for being here today, Koen, and sharing your knowledge and your perspectives on the maternity care. And I think a lot of women can benefit a lot from that.
Yeah, well, thanks for having me. So I'm easily approachable by Instagram,
Yeah,
so I get a lot of DMs. So just share your thoughts and your wishes with me. I always like to hear a new perspective from women. So can wait to meet you all.
that's super cool. I will link your account in the show notes as well.
Thank you.
Thank you so much again, Koen.
You're welcome.
Thanks for listening to Born to Be Wild, the podcast. If you want to continue the conversation, you can find us on Instagram at borntobewild.pt and Birth Mode. We would love to hear from you.
All sources and references mentioned in this episode are in the show notes below. And if you enjoy this episode, of course, please share it with someone who needs to hear it. It's really the best way to help us grow. See you next time!